in the interest of time. So grab the last slice of pizza, grab a chocolate bar, settle in. If you haven't already, please scan the QR code because there's going to be lots of little surveys, very interactive. I'd like to welcome everyone to Grand Rounds for May of 2025. It's been a while because this, until recently, was a clinical space so we really couldn't do presentations here. But we're happy to be back and excited about today's talk. I'm Chris Martin. I'm the Medical Director of Education for one of our intensivists and a co-investigator of the Goals of Care program. So I'm not exactly a non-biased host today. But it's my pleasure to introduce the Goals of Care team and Dr. Giulio Didiodato, who's going to speak about the program, which is soon to go live at RVH on May 26th of this year. So just as a little intro, Giulio's been an intensivist here since 2005. The chief research staff, yeah, no, eh? Round of applause. It's 20-year anniversary. And he's been our chief research scientist since 2018. As part of the Ask Me Goals of Care team, Giulio's collaborated with colleagues to develop, study, and now implement the Ask Me Goals of Care program here at RVH. The Ask Me GOC tool was created by RVH staff to ensure that our seriously ill patients and their substitute decision makers would always have the opportunity to communicate their treatment preferences for life-sustaining therapies in an informed and shared decision-making process. We recently completed the largest randomized controlled trial at a community hospital in Canada. Giulio, along with the other investigators, demonstrated the effectiveness of having one of our registered nurses use the Goals of Care tool to facilitate these discussions. And the results are really positive. It's the results improve patient and healthcare provider outcomes, decrease ICU utilization, cost-effective compared to usual care. Throughout the whole process, Giulio has provided research and logistical support to the team and is really the heart and soul of this program. In addition to each been collaborating with the GOC team, we're now in a scale and spread stage of the project and collaborating with Georgian College and other institutions to try to roll this out provincially and hopefully nationally. Today's primer, we're going to provide you guys with a glimpse of this first-of-a-kind program in Canada. And we're going to tackle how this gap in care that we currently have can be solved with this tool. So let's put our hands together and welcome Giulio.
Thanks, Chris. Andrew Brower just informed me that I guess the poll's already full. I didn't realize it would have a limit, so I apologize. So for those of you who are enrolled, I'm going to depend on you to answer questions on behalf of the rest of the community here. That's a very statistical thing to do, right? We take a sample and then we infer to the population. So that's perfect. Okay. So today we're going to be talking about the RVH Ask Me Goals of Care program that we're going to be rolling out imminently. And it's going to be a bit of a primer, a little bit of an introduction for those of you who've never been exposed to what the Ask Me GOC program actually does. So we're going to review the difference between goals of care versus advanced care plans, because there's a lot of misunderstanding about these two different approaches in terms of speaking to patients and SDMs about their treatment preferences. We're going to evaluate why goals of care are really important in patients who have a serious illness. We're going to sort of define what is an ideal outcome after a goals of care discussion. We'll review a little bit the development of the Ask Me Goals of Care digital tool and the program. And then we're going to review what our program is actually going to look like once we roll it out at the RVH. So for those of you who actually are enrolled in the poll, if you could kind of go through these and sort of identify what you think the most important difference between an advanced care plan and a goals of care discussion actually are, and just pick one. Yeah, I don't want to scroll it because it gets a little bit screwed up. So I apologize for that. But I'll give you 30 seconds or so. Okay, I'll leave it there. So an actual goals of care discussion, the difference is that it leads to an informed decision and consent for treatment. So if you take any patient who may or may not have a serious illness, for those who don't, we generally say we're having an advanced care planning discussion, potentially with a capable patient. If in fact they do have a serious illness and there's some kind of decision that's needed around treatment or care, that then involves a goals of care discussion. If a treatment's not needed, you can go on and have an advanced care plan with either a capable patient to get some sense of their future desires, or if they're not capable, actually identify an SDM, which is one of the most important things that an advanced care plan can do. It does very little else, in fact, for future decision making. But as far as goals of care discussions go, generally, we like to have both the patient and the substitute decision maker available for those discussions. The outcome of the discussion is, in fact, an informed consent for treatment or care, regardless if they receive that treatment or care, especially in the context of someone who has a life-threatening illness and may or may not need life-sustaining therapies. And we always reevaluate these goals of care discussions. It's an iterative process. It's not stuck in some point in time. As people change and their conditions change, so do their goals of care treatment preferences. So why do we need to have goals of care discussions with seriously ill patients? Well, the problem is that if a patient becomes seriously ill and develops a life-threatening illness, about 75% of those patients no longer have the capacity to make an informed decision around their treatment preferences. And the same amount never communicated to either their substitute decision maker or their healthcare provider what their goals of care are. So frequently we're left with not really knowing and a lot of uncertainty in an urgent or an emergent situation. And so we're making decisions on behalf of patients that may or may not have ever been wanted. The consequences, obviously, are a loss of patient autonomy, the ability of a patient to make an informed decision for themselves, delivering care that in fact might either harm the patient or does not benefit the patient, delivering care that has no purpose except to prolong hope, or what we call the hoping for a miracle care, and unwarranted healthcare expenditures. All of these are sort of under the banner of low value care. And in our healthcare system, it's estimated about 30% of all the care we deliver is in fact low value care. So it's a significant problem. In addition, we have a lot of healthcare provider burnout and moral distress. You know, the typical why are we doing this to this patient question that many of us ask ourselves. And a lot of substitute decision makers who don't know what the wishes are of a patient, in fact, suffer a lot of moral distress, and many of them develop PTSD after an event where they have to make a critical decision that may, in fact, lead to a patient's death or withdrawal of treatments. And so that's a significant issue. And we're trying to avoid all of that by having advanced goals of care discussions. So what is the primary objective of a goals of care discussion? I'll give you 30 seconds for those of you that can participate in the poll. Some of you are changing your answers according to peer pressure here. Right? Very good. So we want to balance patients and substitute decision makers' autonomy to make an informed decision with healthcare provider judgment about treatment options. Now, what do we want the result to be? We want to achieve the core principles of ethical decision making. We want to ensure patient autonomy. That is, we want to make sure that they have the ability to make an informed decision about their care. Beneficence, right? We want to make sure that we're doing the right things at the right time. Non-malfeasance, we want to make sure we're not causing harm through the treatments we deliver. Um, Justice, we want to make sure that people have equity to access to care that's appropriate for their condition. And we want to make sure at all times that it's informed. And what we mean by this is we want to give a comprehensive explanation of the prognosis, the risks, the options, and the benefits of all the treatment care options that are appropriate for a patient. Quick little question, given your clinical experiences, do you think that our seriously ill patients and their substitute decision makers are being regularly engaged with appropriate goals of care discussions? That's pretty pessimistic. I'm colorblind, but I think that represents false. Anyway, yeah. I think what this would demonstrate is what we found out in our studies, that most patients aren't in fact receiving what are ideal goals of care discussions within the organization. So how did we develop and why did we develop the Aspen Goals of Care program? Well, it started off as an idea as intensivists that we felt there was a significant gap when we were called to see seriously ill patients, that many of them had not had a really informed goals of care discussion. And we were sort of getting caught in a brouhaha of trying to sort of manage people at the same time as we were trying to sort of get a sense of who they were, what their goals of care were, and what quality of life expectations they had for themselves. We then went on to develop what we thought would be beneficial, which was a digital tool that could be used by any healthcare provider to actually deliver a very systematic and standardized goals of care discussion. Because if you ask someone, well, when you have a goals of care discussion, what do you talk about? There's a huge variation in the content of goals of care discussion. We then developed the tool and sought a lot of stakeholder input from patients, from providers, from families. And then we put that digital tool to a pilot test. And we did that in 2019. And at that time, we actually had a physician assistant, Monica, who actually used the digital tool to have a facilitated goals of care discussion with patients and their SDMs. We ended up publishing this paper, and we learned from this pilot study that, one, it was very well received by almost everybody who was exposed to the tool. There was a lot of concern that having these really comprehensive discussions would not be well received by patients and their families. And in fact, the exact opposite was true. Almost every family consented to having a goals of care discussion by someone who was not even in their primary circle of care. That was another barrier that we thought we'd come up to. We were worried about physicians not giving us access to their patients. And in fact, when we asked physicians, could we approach their patients, the vast majority of physicians felt very comfortable allowing us to go talk to their patients about goals of care, even when they themselves had had a goals of care discussion already and was well documented. So we found that the tool and the approach was quite feasible within our organization. And of course, anytime you do a pilot study, the reason to do a pilot study is because you're intending to do a much larger study using what you've learned from that pilot study. And so back in 2018-19, we wrote a protocol, or sorry, after 2020, we wrote a protocol for a very large randomized controlled trial called the Assessment of Shared Decision-Making Tool for eliciting informed goals of care in the hospitalized elderly, a randomized trial. And like every good study, if you don't have a good acronym, your study's going to be crap. So I thought our acronym was very, very good, and our study was very good as a result of that acronym. So we did the ASPE GOC study. It was an RCT where we randomly allocated patients over the age of 80 who've been admitted to hospital for at least 24 hours, but were ward-based. This was not used in ICU patients. This was used in ward-based patients. We randomized them either to the tool, to the facilitated goals of care discussion versus usual care. We enrolled 1,906 patients with equal groups in each patient. So you have a little infographic on your table that shows some of the results that we found at the end of our study. But needless to say, I think the results we found were quite consistent with sort of the quintuple aims of an effective healthcare system. We showed improved patient and healthcare provider outcomes. We decreased low-value healthcare utilization, and we showed improved cost effectiveness. And so we're really pleased with the results of the study so far. The study is still ongoing. There's a very large qualitative component where we're about to embark on interviewing patients and their families about their impressions of actually being exposed to the tool. And we're also looking at 12-month outcomes after hospital discharge and those people who survive to see if, in fact, the conversations we have a long tail. That is, are they still remembered by patients when they get rehospitalized, and can they refer back to them and still be consistent with their current goals of care? Okay, now, this poll source says, identify your experience, if any, with ASPE-GOC. We obviously had a lot of our study nurses going out and about the organization, talking to patients, and so wanted to have a sense of if any of you had actually been exposed to the ASPE goals of care, either as a result of your patient being interviewed or indirectly through word of mouth. Okay, well, at least some of you are honest. That's good. So a meaningful amount of people who are just here for the food also had sort of some exposure through interactions with their actual patients. For those of you who were actually exposed directly or indirectly, did you actually feel it was helpful for your patients or their families? Okay. So, you know, a significant majority sort of felt, yeah, it probably was a little bit helpful. So what is our program all about? Well, our program is about creating a service where we deliver what's called the facilitated goals of care discussion. It has two novel sort of contents. One is that we believe any healthcare provider can actually participate in a facilitated goals of care discussion if given the appropriate training and tool. And the tool is our digital tool, our ASPE-GOC digital tool. Now, in our study, we used very knowledgeable sort of people who have a tremendous amount of experience with life-threatening illnesses and life-threatening, or at least life-sustaining therapies, and that was our ICU nurses. We had a core group of ICU nurses who were trained on the tool, and they were responsible for engaging patients and SDMs in these facilitated goals of care discussions. This is a little bit of a longer question, but wanting to get a sense of, you know, who, you know, what criteria should we use to identify patients that we should be having goals of care discussion with? So some of the things are age, acute severity of illness, pre-hospitalization functional status, presence of chronic end-stage organ failure. The one you can't see there is attending physician opinion. We obviously in our study used age as the only criteria. The reason we did that is that in the ICU world, there's very equivocal evidence whether ICU care in those over the age of 80 actually provides long-term benefits. That's why we picked that age. Well, we weren't trying to be ageist. It was just the reality of what happens in an ICU environment with the very elderly. We recognize, of course, that there are other reasons to have goals of care conversations with patients. So ranked first here is pre-hospitalization functional status, measured by some measure. Someone with chronic end-stage disease, then acute severity of illness, age placed fourth, and then attending physician opinion was placed last. So that's very interesting that was chosen, because we did change the criteria for the upcoming program in terms of who we should be actually reviewing. And in fact, we're incorporating that pre-hospitalization functional status within the eligibility criteria along with age. So there are going to be two ways that our ASPE-GOC staff are going to be notified to see patients. One is through what we call our default consultations. Our default consultations are going to occur in patients who either have a Canadian Clinical Frailty score of 5 or higher on admission, or their age is over 80. We'll have a report that's generated every day of patients who are hospitalized for at least 24 hours that identify these patients. And we'll go see the ones that either have no code status documented or have a code status that could involve a transfer to an ICU. This is sort of an extension of the criteria that we used in our study. For the upcoming program, we had a lot of requests during our study, direct requests, to have patients be seen by our staff. We, of course, couldn't do that because we were doing a study. But because of that, we've also have a new way to have consultations or identify patients, and that's a direct consult from attending physicians. And again, the criteria are hopefully that someone is very frail, or they're very elderly, or perhaps they have other criteria, such as having at least one chronic end organ failure, or answering no to the surprise question of would you be surprised if this patient were to die in the next 12 months, or the code status didn't seem to be aligned with the attending physician's opinion, meaning a family is requesting interventions that an attending physician thinks are not appropriate for where that patient is in their life course. And again, we're restricting the patients we see to those who have a code status that might involve a transfer to an intensive care unit. Who are we not going to see? We're not going to see young people, so no one under the age of 18. We're not going to see people who are imminently ready for transfer. We want to assess people who are recently hospitalized, are still sort of in the treatment phase of their illness, and could have issues that come up that might require an admission to an ICU. We're not going to see people who have been admitted on a Mental Health Act form. We're not going to see people who are inpatients at a birthing unit, postpartum area, mental health, or ICU, and we're not going to see outpatients in any clinic that may be going on in the hospital. We talked about patients who have a new cancer diagnosis on their index hospitalization, whether we should see them or not. We felt that it was most appropriate that we would only see those patients as a result of a direct consult from an attending physician who felt that the patient may benefit from an Ask Me GOC consult. And we won't see people who in our system have a code status that is either supportive medical or palliative, because in those particular treatment preferences, there's no real indication for transfer to an ICU. How are we going to prioritize our goals of care consults? We're going to try and prioritize direct consults first. So if we get a direct consult from a physician or their delegate, we were going to, and for whatever reason, doesn't matter why they're asking us to see them, our team is going to prioritize those consults. We are going to try and complete those consults within 2 business days so that at least we have an efficient way of documenting care preferences in a timely manner. For those patients who are either direct or default consultations, the clinical frailty scale will be the highest ranking device. So those with a score of 9, which generally means they're palliative and imminently terminal, will be seen first before those who have a score of 5, which suggests some mild to moderate frailty. And age will be the last criteria that we'll use. Well, we'll see the most elderly first compared to the least elderly. So that's how we're going to sort of prioritize our consults. This is a bit of a longer question and you can't see all of it, but you know, we built the tool, again, with the full anticipation and expectation that anyone trained appropriately could actually have a goals of care conversation with patients and their SDMs. We're not sure, though, how acceptable that is to other people, including healthcare providers, especially those within the primary circle of care. So I'd put a very, very long list here of healthcare provider groups and specialties that maybe could be considered to be most appropriate to least appropriate of having a goals of care conversation. So for those of you who can, if you would try and rank them, we'll get a sense of at least the top 3 or 4 of who you would feel most comfortable with having a goals of care conversation. I'll give you a sort of a minute to do it because it's a little tricky to do it on the poll. You've got to move these things up and down with arrows. But maybe focus on your top 3 or 4 as opposed to the entire list. Always a little concerning when the non-ICU attending physician isn't kind of near the top of that, but there's probably a lot of ICU nurses here today. So certainly it looks like, at least in the top categories, physicians and nurses, and there's a physician assistant, moving up the ranks, would be appropriate. As I've said, we've already used a physician assistant to actually deliver these goals of care, and it was very well accepted. We've now had, obviously, our ICU nurses do it with incredible success. And we intend, over the course of the program, to hopefully include other interested healthcare groups and specialties who might want to participate in this program to see if there's any differences in who actually delivers a facilitated goals of care discussion using our tool. Logistically, our service is going to roll out and start on May 26th, so we're very pleased about that. It's going to initially be a Monday to Friday service with no holidays. It's going to run from 11 a.m. to 7 p.m. We learned that from our study. Our nurses initially were running our program from 9 till 5. There were a lot of families and substitute decision makers who could not come until after work. So we thought we'd start later in the morning and end later in the evening to try and accommodate family members and SDMs. And we're starting off with 8 wonderful nurses. We have a direct extension, just like CCOT. We wanted to make this program look very much like CCOT. So like CCOT, there's a dedicated extension of 46628. Our nurses will carry a dedicated phone that also has hypercare on it. There is a referral that a physician or their delegate can make within Meditech called the referral Ask Me GOC Goals of Care. If that referral is made on weekends or off hours, it won't be obviously responded to until the following weekday. And then there's also the possibility of directly texting someone on a hypercare. So a physician can text our team at the 46628 number and ask them by providing a V number if they could go see one of their patients. So those are the ways we hope that the direct consults can actually be referred. All right. I wasn't too pleased about this poll, but I thought I'd throw it in. One of the things we shouldn't talk about when we're conducting an Ask Me GOC that we won't talk about for sure. Interesting. Okay. All right. Well, we're certainly not going to talk about the previous goals of care discussions that may or may not have occurred between an attending physician and their patient. But what we will talk about and what our program contains, our digital tool contains, are 4 distinct modules. It has a pre-hospitalization module that contains information around health status and changes over time that are self-reported by a patient and or their SDM. A second module that contains the current reason for hospitalization, that is, does the patient even know why they're here and what treatments they're getting, and then their prognosis for survival to hospital discharge. The third module contains the what if scenario. Now, we picked in hospital cardiac arrest because most patients and their families understand what it means when a heart stops beating. Families have a much more difficult time understanding things like sepsis or respiratory failure. So we wanted a black and white scenario to represent the catastrophic illness that can happen in hospital. And we talk about in-hospital cardiac arrest and the prognosis. And then lastly, our module looks at the values and goals of treatment that these patients have, along with feedback from an algorithm that we've built into the tool about what intensivists might offer patients in their circumstances, given the information they've provided to us. And that's really important. We didn't have that in our study tool. And we found that a lot of patients, despite having gone through an Ask Me GOC consult, and I think recognized that maybe their expectations were not consistent with their treatment preferences, there was no real feedback except through our ICU nurses about whether the choices they were making for themselves were appropriate or not. We've built an algorithm in with, as a result of all of our ICU programs, opinions that gives feedback to a patient and SDM about the appropriateness of what they're asking for given their current clinical condition. And the tool tries to do a lot to educate patients and their SDMs around the risks and benefits of treatment. So we spent a lot of time building in a lot of visual modules and textual modules to help explain what treatments are available in the ICU and what are the risks and benefits of those treatments. What happens once the consultation is done? Well, our ICU nurses will review that consultation with the most responsible physician. And they'll do that using hypercare as a way to transmit this acute care summary, so this Ask Me GOC summary, which is on the right-hand side for you. The summary is essentially an automated PDF that gets generated from the consultation we do that shows everything that we've really discussed with the patient and their SDM. And we'll transmit that through hypercare as a PDF that an MRP can review. And we'll also communicate whether there's a request for a change in code status with the MRP, if applicable. As far as documentation goes, there will be a report section. So in the report section, as it was in the study, we downloaded or we documented everything we did in the report section. We are going to have a goals of care progress note there in which that summary will be uploaded, and then there will be some canned information that will include to supplement that summary. If there's a requested change in code status, currently we're still working with professional practice. At this time, that will be the responsibility of the attending physician. In our study, for those of you who were exposed, it was the ICU physicians, the co-investigators, Doug, Osgard, Chris Martin, and myself, who actually made the changes in Meditech on behalf of the MRP. We're no longer doing that. So it'll be the MRP responsibility. So either they'll have to complete it themselves in Meditech, or through a verbal order to our Ask Me GOC nurses, they can actually get our nurses, our program nurses, to change the order on their behalf, given the same restrictions that commonly exist for verbal orders in the organization. These are the ICU nurses that are going to be starting off and running our Ask Me GOC program. Melanie is going to be our team lead, but Amy, Sandra, Riley, Amanda, Pearl, Riley, and Kirsten are fantastic ICU nurses. 5 of them actually were our research study nurses who have now have hundreds upon hundreds of hours of conducting goals of care conversations. And so they're really adept and really good at using the tool to have facilitated GOC. And I think we're really, really lucky to have them as part of the program. You know, we've had a lot of success with this study. I mean, when you have an idea, you really never know, is it actually a reasonable idea? Is it a good one? Obviously, when it's your own idea, you're quite biased into thinking it's a useful thing. But I think we've had a lot of external validation of the value of what we're doing. We had a very large initial grant through the RVH Foundation to actually support our RCT. But since that time, the Ask Me GOC tool has received a lot of awards. We were a finalist in the Excellence in Healthcare Communication in the Ontario Health Systems Quality and Innovations Award. We received a very large grant to actually spread the tool outside of the RVH to other organizations such as hospitals, primary care practices, and long-term facilities, and we're currently doing that. And most recently, we won first place in the High Value Care Award section at the American College of Physicians of Internal Medicine Conference. So, this tool is being recognized locally, regionally, provincially, and internationally. And so we're very confident, we think, that other people see the same value that we see. I mean, I don't know that I captured everybody on this slide, but I came pretty close. We have a huge team of people, Doug, Chris, and myself, who are the co-creators and investigators. The Research Institute has been unbelievable in their support of our program. Obviously, the Ask Me GOC research nurses and now the program nurses have been indispensable, and nothing would have been achievable without their involvement. Our ICU program, our intensivist colleagues, tremendous influence. We've worked hand in hand with Georgian College Computer Sciences to develop the digital tool, and they've been a wonderful partner in our ability to actually develop this tool way beyond to what we started with, which was quite a rudimentary tool when we did our pilot study, but it actually looks quite beautiful now. And I can't go on and on. I don't want to mention everybody, but thank you to everyone who's helped us along the way. That brings us to the end of the presentation. I'm obviously happy to answer any questions here. For those of you who might want to talk to me privately or talk to Chris or Doug, please approach us at any time. We'd love to hear your opinions, your concerns, good or bad, about the tool. We want to continue to develop it and make it like an indispensable tool, not just in our hospital, but honestly outside of our hospitals, that all patients have access to the tool. We have a wonderful website if you want to learn more about the tool that I've listed there. And for those of you who are interested in seeing what our preliminary results are, you can certainly scan on the QR code and have a look at some of the study results from our Ask Me GOC. So I'm happy to take any questions that anyone may have. And thanks for coming.
So much question, Lauren, when the mic back to you.
That's great. Is any of this material going to be available in your pamphlet or website that you could offer your patients to kind of point patients that these questions would be appropriate as well?
Yeah, so we have developed an information pamphlet that will be available to all patients in the hospital when they come in, so that they can have a little bit of a preamble about what the program is, especially if they get exposed to it. There's going to be sort of, we are making a push, honestly, Lauren, to get this out into primary care practices, chronic disease clinics, and long-term care facilities. So we're working with lots of partners because we have different versions of the tool that we've created that are more appropriate for those outpatient populations. Chris's ultimate hope is that the tool becomes simple enough to be self-administered by a patient and their SDM. And so available through some kind of website where families can just go on and do it on their own. We're not there yet, but that's where we'd like to get to.
Thanks, Giulio. Amazing presentation. Are you looking into creating some type of an app like for phones? This would be very handy, especially nowadays that everyone's using a cell phone, and also most of the healthcare providers, they've given an iPhone institution, so they can easily focus on an app. I just think that it's probably a bit more easier to use that way. And it beats the logging into the computer. But also, I really appreciate if, once you expand this into primary care, that we can have like brochures and pamphlets and sort of links like QR codes, so that patients, while sitting in a waiting room, they can kind of log into this, look at this. I think the main value of this that I'm thinking about is really as outpatient, where goals of care are already determined in the frail, aging population ahead of time, even before the time of a hospital crisis situation. So there's that general awareness in the population. I think this is really going to be, it's going to be very helpful.
Yeah.
For the overall population.
So to your first question, I mean, it's a web-based app, so in theory you could use it on your phone. It's not it would be very difficult in terms of visual acuity, like especially if you think the type of patient who would generally be using this kind of app. I think it would be difficult for them to visually see on a phone, on a device that's a phone. We haven't gone down that route to make it into an app yet. I think we would need to think about what that looks like, because I think we'd have to structure its presentation very differently than how we've structured it on an iPad or on a tablet device. I don't want to say an iPad, a tablet device. Our website is very informative. It's very we worked with Georgian College to develop it. It's incredibly informative. It doesn't have access to the tool. In other words, you can't just register and go in and play around in the tool. But I think that's something that we can think about. As I said, we want it to be so simple that it can be self-administered in an understandable way. Ideally, we would love to have a system like the Alberta healthcare system where people can now register in a central registry what their advanced care plans wishes are. Ideally, when we do something like this, looking into the future, if you know you have a systematic and standardized way that people get exposed to a goals of care conversation, it's not a very far leap then to say, well, is there a place where we can register what their treatment preferences are? And that would need to have a central registry. So that's, again, a thing that we're looking at in the future that we'd like to make the case for, quite frankly. This is really a huge commitment that the RVH has made to supporting this program. I don't think there's another program like this anywhere else in Canada. There are programs like this in the United States. In fact, we're working with a hospital corporation in the United States who run a similar program to what we do, but they don't have the digital tool. And in fact, they want to use our digital tool to supplant or support the current work that they do. And so we're in the process of actually setting up a relationship with them to see how it works in a very different kind of system. So we have a lot of ambition about moving this program outside the RVH, but we desperately right now want it to work well for our patients. And I think hopefully as we learn from our study and as we'll learn from our local running of the program, that there's a lot of improvements and iterations of the tool that it will have to undergo to make it really, really useful for patients and their families and hopefully healthcare providers. So I think everything you've mentioned is on our radar. We're just getting our feet wet and trying to understand how best to do it.
Good question. And the clinic version is really important, I think, because your actual clinics and all these clinics, that's all the time before they get to the hospital. So we're really happy to show anyone the clinic version, which instead of having like, oh, what do you want in the ICU? It's actually something like there. Do you want to go to the hospital? I think is that the best place for your care is our emergency department and admitted to the hospital versus staying where you are at home or staying in the retirement nursing home.
I apologize if I missed it. I did miss the first couple slides. I just want to clarify, is it a physician-only referral at this time for RVH, or can it be entered as a therapeutic referral? Like from nursing teams, if families and patients are asking for this, can it be referred therapeutically, or does it have to be a physician-only referral?
So right now, it could be a physician and or their delegate. So what we're hoping is if a nurse, a physiotherapist, a pharmacist runs into a situation where they really feel compelled that a goals of care discussion really needs to occur, our hope is that they will notify the MRP and say, hey, I think it'd be a great idea if you put a consult in for Asthma GOC. And nurses can go into Meditech and fill out the requisition order for a physician, like a verbal order. So that can happen. But we're hoping that, again, we fundamentally believe that a goals of care discussion shouldn't be the sole purview of physician. We've obviously created a tool and we've done a very large study that suggests that that's true, that other people can participate in these conversations. But there's nothing unique about what a physician does or says that should only restrict these conversations to a physician and a patient and their SDM. And so what we also want is global participation in identifying those patients who we should be seeing. And the mechanism right now is not a direct referral from an allied healthcare provider to us. It still has to flow through the attending physician.
Question, any other questions?
Thanks so much, Giulio. I'm so proud to be part of an institution that's prioritizing these conversations, and I think it's so important. I'm just wondering, as a point of curiosity and maybe oblivion on my side, is the clinical frailty scale something that's already being documented for patients on admission? And if so, where do we find that?
Yeah, that's a great question. So we kind of, from a timeliness perspective, got lucky in that the emergency department, along with the acute geriatric service, was looking to implement the Canadian Clinical Frailty Scale for themselves. I think, and I might be wrong about this, in people over the age of 65. So that documentation is going to be occurring, hopefully, regularly, by the primary ER nurse. That's my understanding. So we're going to piggyback on that. And where exactly it lives at Meditech, I'm not sure. But it lives somewhere where it's visible. And I think it's either already, and Sharon could answer this. I don't think she's here, but oh, she is. Okay, Sharon could answer this better, exactly when the start date is for the collection of that data.
So I don't have the exact date.
Yeah. Yeah.
You want to live in Meditech?
It's I think it's going back to the deal exactly and send that to you.
Yeah. Yeah, we think, you know, it's one of those things that Meditech has the capacity to document that. I think most electronic medical record systems do. There are many frailty scales. As far as my understanding and my reading of the evidence, there's not any particular one that's necessarily any more predictive of outcomes than any other one. We like the Canadian version. Well, one, it's Canadian. Two, it's very simple to use. Our nurses are very familiar with it because they actually documented the CFS on our research patients. So they were responsible for getting and documenting that information. So they're very familiar with that scoring system and very good at being accurate in their assessment. So yeah, so it's great, and it's just fortuitous that ER and the geriatric program were asking for it at the same time. And I think because two separate programs were asking for it, I think it became a much higher priority. And it's great that our ER colleagues, despite having a billion things that they have to do, will be collecting that data for us.
Any further questions? If anyone does want the tool itself, reach out to Giulio, Doug, or if you see any of our research or now program nurses around, and we're happy to show you. And yeah, feedback is always important. This is version 3 of the tool currently. There will be version 4, so all feedback is welcome and encouraged because, like any other software program, it takes a while to get it really bad. So thanks everyone again. I just want to give another round of applause to Giulio.